This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Justin Abbatemarco from the Cleveland Clinic, here with Divyanshu Dubey to discuss his article published in eBiomedicine, Neural Synaptic Vesicle Autoimmunity, following aerosolized porcine neural tissue exposure, insight into autoimmune inflammatory polyradicular neuropathy. Div is a professor of neurology at the Mayo Clinic in Rochester, Minnesota, where he co-directs the Neuroimmunology Lab. Hello and welcome.
Hi, Justin. Thank you for having me.
It's really cool to have patient cases inspire basic science research and help inform clinical care. Can you talk about that original cohort? What happened? How did you go down this journey?
The story began in 2006, 2007, or 2008, when a group of swine abattoir workers who developed a striking neurological syndrome. What stood out in these patients was the localization. These patients had a very unique autoimmune neurological phenotype where electrodiagnostic studies as well as MRIs and CSF findings all suggested there was an underlying autoimmune disease affecting the peripheral nervous system, and in some cases also affecting the central nervous system with some lesions in the brain or the spinal cord. The interesting thing about this was the proximity from the head of the table. This is the place where a compressed air extraction machine was taking off the porcine brain and in turn aerosolizing this neural material into the room. Wherever this machine was placed, closer a worker was to this machine, more likely he or she was to develop this disease. And interestingly, closer the worker was to this machine, more severe was the disease in these particular individuals. So it is unfortunate, but it is a very interesting autoimmune mystery that happened more than about a decade ago. Since I joined the lab here at Mayo Clinic, this was one of the things I wanted to always go back to try and understand this disease and interpret how the findings from about 10 years ago can help us understand, or even 20 years ago, can help us understand what is going on in our patients, which we see in our clinic today, both in the autoimmune neurology clinic as well as in the peripheral nerve clinic. Dr. Lennon had previously worked on the tissue immunofluorescence assay of these patients and demonstrated that these patients had a very unique synaptic staining pattern, which further was intriguing and suggested there was an underlying autoimmune disorder. And then a lot of work done by Dr. Dick and colleagues with nerve biopsies clearly suggested this was an inflammatory neuropathy, which had a very peculiar phenotypic characterization with mixed axonal demyelinating features, with sensory predominant presentations, with neuropathic pain. So all this sort of was one of the reasons to go back to this theory many years later. The challenge was getting the samples. Despite how systematic things are sometimes in research, finding samples from 20 years ago can be challenging. And we tried to search our refrigerators and we couldn't find any. Thankfully, Dr. Lennon had sent off some samples to Dr. Corral to do the autoimmune nodopathy biomarkers in these cases, neurofasciin, contactin, Casper-1, which all of them came back negative, but that was the source that we could tap into and reach out to get the samples back to Mayo Clinic to get this project started. And I was lucky enough to have a very strong team working with me, with Dr. Hinson, who's a senior developer in our lab, and Dr. Gupta, who's a postdoctoral fellow, currently a neurology resident in Wayne State. And we were all able to put our heads together and try to understand what can we learn from this story, which began in 2006 to 2008.
It's such a cool story, and I agree. Spanning such a long time, lots of team members involved. But starting at the bedside, this acute clinical insight, really digging into occupational exposures, I don't know, it's humbling and maybe inspires me to do a little better in the clinic. We all see these mystery cases sometimes.
Yeah, and that's what a lot of inspiration for our research comes from. It comes from seeing patients, and sometimes seeing patients where we don't necessarily have all the answers. And that's what at least drives my research, at least in the neuroimmunology space.
The initial lab work showed some evidence of voltage-gated potassium channel antibodies without clear evidence for LGI1 or Casper-2 positivity. Can you talk about how you think about those results today, and how did your lab evolve after that?
So you can imagine this work was done even before LGI1 and Casper-2 were readily available or even identified or widely accepted as biomarkers of autoimmunity. And back then, voltage-gated potassium channel antibodies, as you suggested, did come back positive in many of these patients who developed this autoimmunity following the aerosolized neural protein exposure. But now, in hindsight, we recognize that patients who have antibodies to voltage-gated potassium channel complex but are negative to antibodies against LGI1 and Caspr2, like these patients were, the antibody to voltage gated potassium channel complex is usually not a specific marker of neurological autoimmunity. So knowing that these patients were positive VGKC, but not LGI1 Caspr2, but had a unique synaptic staining pattern suggesting there could be something else going on was, again, the reason to go back to these samples. And then our further workup showed that voltage gated potassium channel was probably just a biomarker or a red flag of something going on, or systemic autoimmunity or neural specific autoimmunity going on in these patients. But the true disease was being caused by other neural proteins, those being triggered by the neural synaptic vesicles.
And I think it's like a perfect segue, right? There was a suspicion that it was an immune mediated. We just weren't getting our finger on the target, and it inspired this latest work. So what did you find there?
So we used a technique called as phage display or phage immunoprecipitation sequencing to evaluate the archived sera from patients with these abattoir worker cohort. And two dominant neural antigens came through in majority of the cases. One was synaptophysin and another was GAP43. So synaptophysin is a synaptic vesicular protein, which is integral to the integral protein in the membrane of the presynaptic vesicles, playing a critical role in vesicular trafficking and neurotransmitter release, whereas GAP43 is a growth-associated protein abundant in the axonal growth cones and presynaptic vesicles. So both of these proteins are either part of the presynaptic vesicles or closely associated with the presynaptic vesicles and are essential for maintaining synaptic integrity and communication between neurons. So once we identified these antigens as one of the top hits in majority of the patients, we subsequently validated these phage display findings using multiple other methodologies like enzyme-linked immunosorbents assay or cell-based assay to feel comfortable and confident that what we were seeing was real and truly could be translated into down the line tests if it stood the test of our clinical analytical validation or specificity testing. In the majority of the occupational inflammatory polyradicular neuropathy cases, that's the term we used for the swine abattoir workers developing this autoimmunity. These OIPN cases were mostly positive for synaptophysin, but majority of the cases along with synaptophysin also had antibodies to GAP43. There are a couple of cases which were just positive for GAP43, but the synaptophysin was negative. The numbers were not big enough for us to tease out the phenotypic differences between the synaptophysin and GAP43 combined versus the GAP43 only or the synaptophysin only cases, but there were enough similarities to describe them as a clinical syndrome. What was interesting was we did see a trend in the synaptophysin titers and disease severity, which was graded based on neuropathy impairment score. Again, goes back to that initial idea that was put forward by the previous researchers. Closer a person was to the head of the table, more severe was the disease. And then it turns out there was some correlation in the titers of the antibodies as well. And then what was most interesting was, in addition to finding these antibodies in patients with inflammatory polyradicular neuropathy secondary to occupational exposure, we also found these antibodies in other inflammatory polyradicular neuropathy cases who never had history of this exposure. Because in our clinic, we see these patients all the time, and there isn't a biomarker to help us to diagnose these patients. But having the resource here at Mayo Clinic, where we have a lot of samples stored from well-characterized patients, I was able to go back to that pool to try and understand relevance of these findings in current clinical practice.
There's so much there. And the story is just so interesting. And I agree, trying to extrapolate this beyond just people who are working in these obviously very specific occupational exposures and how it really helps inform care. I was wondering if you could take a quick aside and talk about the phage display technology, because it's so cool. How that technology works and how is that helping our understanding and discovery of neural antibodies?
This all starts by initially building a massive phage library. And the initial impetus to pursue this unique technology came from our collaboration with UCSF, which led to the discovery of Calch11 using this unique technology. And then back in 2019, in the middle of COVID pandemic, me and a couple of my other research collaborators put our heads together to start building our own library here at Mayo Clinic. And what that entails is introducing or adding small oligopeptides representing the entire human proteome as a part of the core protein of bacteriophages. And these are thousands and thousands of bacteriophages in each particular tube or each particular ml of this floating bacteriophage milieu, which in turn is then utilized to study what a person's immune signature looks like. The way we do that is we mix the patient's serum or CSF or plasma with this bacteriophage solution or sort of bacteriophage culture and allow the antibodies to go and identify the proteins they are targeting. After an incubation period, a patient with autoimmune disease or a patient with cancer, those antibodies go and bind to certain bacteriophages, and the rest of the antibodies remain unbound. The next step includes immunoprecipitation, where we use protein AG beads to pull down the antibodies which are bound to bacteriophages. Then those bacteriophages which are pulled down with the antibody are lysed. The DNA is released. The DNA is amplified using a PCR process. And then this all is barcoded and sent off to sequencing. The unique thing about this technology is, in addition to allowing us to study more than one antigen at a time, truly understanding an immunofingerprint of an individual, it also has a high throughput capability where we can test 100 samples at once. So it is truly revolutionizing how we are approaching biomarker discovery in our neuroimmunology lab, and then has implications beyond just these autoimmune neurological diseases like inflammatory polyradicular neuropathy. Is also helping us study people's immunosignatures in response to cancers, in response to neurodegenerative diseases. There are a lot of other uses for this technology, giving us insights into neuroscience in general.
And then I want to build off your other response, talking about this latest paper. So again, we're not all going to see these occupational exposures, but in your work, you were able to prove that these antibodies seem to be at play in non-occupational exposures. And then you use this term as other immune-mediated polyradicular neuropathy. Could you talk a little bit about that? How does that present to you in clinic? How do you think about that, especially before these antibodies, and how does this latest finding help and maybe inform care moving forward?
Yes, that's the most important part of the study, because I hope most of us or all of us never see again occupational inflammatory polyradicular neuropathy. But we do see patients who have these proximal nerve root or plexus involvements which don't seem to meet the diagnostic criteria for either CIDP or GBS. In our study, most of these patients that we called as other inflammatory polyradicular neuropathy were in their 50s or 60s, more men than women, and had an asymmetric onset of neuropathic process with asymmetric onset of pain involving one leg, and then in some cases transitioning on to involve the other leg, showing the progressive nature of this disease. The localization of root or plexus involvement was confirmed not only by the clinical presentation and examination, in most of these cases supported by EMG as well as MRIs performed in some of these patients. These patients on electrodiagnostic studies had evidence of a mixed axonal demyelinating picture in some cases, and many of these could be like a secondary demyelination from the axonal loss which is driving the disease process. Some of these patients were clinically being characterized as non-diabetic lumbosacral radicular plexus neuropathy. There were other cases in the study which were paraneoplastic polyradicular neuropathy and intermediate risk paraneoplastic diagnostic criteria suggested in the updated paraneoplastic syndrome paper. So there was a bunch of different groups which had a very similar phenotypic characterization, but not necessarily meeting the criteria for well-known autoimmune neuropathies like CIDP or GBS, which were put into these cohorts. And as I mentioned, this is not an uncommon form of neuropathy that we come across in our clinical practice. So the findings of the study, where using biomarkers such as synaptophysin and GAP43 in our clinical practice, can not only help us diagnose these patients, but also start them on immunotherapy, because that most of the patients who were in the study, who were started on immunotherapy such as steroids or IVIG, actually responded favorably. Not only the pain improved, their disability from weakness and numbness and gait instability also improved, which sort of brings us back to the current day and our current clinical practice, how this research from samples from about 20 years ago can actually truly help us today with our patients.
Yeah, to have a biomarker to potentially follow along, to give us more confidence, because these patients weren't traditionally fitting into a bucket that we would think about AIDP, CIDP, those other diseases. And I treat mainly central nervous system disorders, but on inpatient service, you would see these cases. They were so challenging, and you'd have this gestalt that it's immune-mediated, but to have a biomarker really helps inform care.
Currently, the way we identify these patients is, as you mentioned, very clinically focused, where it's purely based on phenotypic characterization, to some extent helped by our current ancillary studies such as EMG, MRI, and spinal fluid analyses. In a lot of these patients, we have to pursue invasive procedures like nerve biopsy to support a diagnosis of an inflammatory process, because ultimately right now the way these patients are being diagnosed is a diagnosis of exclusion, trying to rule out other possibilities. So availability of these blood tests, once they go through a very rigorous clinical and analytical validation process, can actually help us in the long run. You can imagine if somebody has hematological malignancy, was the case in some of our patients, presented idiopathic inflammatory polyradicular neuropathy, and has this sort of nerve root plexus involvement. Things like neurolymphomatosis, amyloidosis are all in the differential, all the things that we are thinking of when we are seeing these patients in clinic. So having a blood test segue towards an autoimmune etiology and in turn help us not only diagnose these patients, but then put them on treatment promptly, can actually lead to considerable disability reduction in these cases.
No, so helpful. And then maybe following up, is there a strong paraneoplastic phenotype? How should we think about these cases? Should we be screening specific areas, or is it a lower risk syndrome?
So far, based on what we've seen, only a couple of cases in our study had a paraneoplastic association. But synaptophysin is a known immunohistochemistry marker, which is utilized to tell if a tumor is neuroendocrine or not. So it's a neuroendocrine marker. And one of the patients in our study did have small cell lung cancer. Similarly, there were patients with hematological malignancies, as I mentioned before, who truly had a paraneoplastic polyradicular neuropathy presentation. So even though currently the numbers may qualify these antibodies into potentially in the low risk category as defined in the paraneoplastic diagnostic criteria, I think as we gain more and more understanding of these biomarkers, there's a chance that may change over time. What we might also see, similar to other paraneoplastic cases, when the patient truly has a paraneoplastic disease, there might be even more multifocality involved with potential central nervous system involvement in some of these cases, as we did see already, both in the swine abattoir workers who were positive for synaptophysin, but also in the other autoimmune cases who never had exposure to aerosolized brain, where a couple of cases did have CNS involvement as well. So that's another thing I'll keep an eye out for as we gather more and more cases positive for these antibodies. How does the phenotype expand and give us more insights into capturing these patients?
So more to come there, but I appreciate that multifocal comment. There should be maybe some other clues that would really drive us to look for cancer. So maybe the $1 million question is like, how does this work help inform our understanding of neurological autoimmune diseases?
That's a very interesting question, because there are multiple things from this study which are very interesting and actually drive a lot of future research. One of the interesting things is how the disease was actually caused in these patients, where there was inhalation of these neural antigens. And now we know potentially through these synaptic vesicles which pass through the blood alveolar barrier and somehow were able to excite the systemic inflammation, and in turn driving an antibody and potentially a T cell response to neural antigens expressed at the level of the peripheral nerve, as well as in some cases crossing the blood brain barrier. So you can imagine how strong the response would have been. So that's one area of study that sort of guides a lot of research and understanding environmental exposures and their role. The other sort of more actionable findings from these antibody discoveries is now in turn the study of pathophysiology of how these neuropathies are caused. So we did do a lot of work in trying to stain rat hippocampal neurons as well as iPSC-derived sensory neurons with patient samples, and saw that patients who had strong synaptophysin positivity did show some live neural cell binding, potentially suggesting there might be some role of direct antibody-mediated pathogenesis. Further work needs to be done to try to understand, do these antibodies stop the vesicular traffic between nerves? Is that a mechanism that can potentially work in autoimmune disease? But that's still a hypothesis and requires more work. So that's another sort of a segue or potentially a rabbit hole that we can go into in trying to understand autoimmunity at the bench level. Among the patients, as I said, trying to study not just the expanding phenotypic associations with these antibodies, but trying to understand the natural history of disease. So when you diagnose a patient with synaptophysin or GAP43 autoimmunity, how best to treat these patients? What are the chances of relapse in these patients? How long to treat these patients? Those are other very important or very relevant clinical questions that still need to be answered and require further study.
Again, these antibodies aren't commercially available yet, but how are you changing your clinical practice? How should other neurologists think about this today when they're seeing patients?
So one of the things that we are actively working on is potentially thinking about launching these antibodies as clinical tests at some point back in 2026 or 2027 to not only provide this service to neurologists all over the world, but also grow this cohort of synaptophysin or GAP43 positive autoimmune neurological diseases to, again, further study the impact of these neuropathies and impact of these antibodies among various autoimmune neuropathies. So that's something we are actively working on. It would require time because we want to do it in a systematic manner through a very careful verification and validation process. So once we go live, the goal would be to minimize or potentially not produce positive results, because in our clinical practice, as we've learned from the VGKC story, if the antibody lacks specificity, it can cause a lot of damage instead because of unnecessary immunotherapies in some of these cases. The other thing which will be helpful, as we mentioned in an answer to one of the previous questions, is availability of these biomarkers in clinical practice would in turn help us counsel patients and treat patients, and not only counsel them in terms of what is the best way to treat these potential autoimmune neuropathies, but over time we'll gain enough understanding into this disease that we can talk about natural history of disease and how do the next couple of years look like. These biomarkers will not only provide additional diagnostic evaluations, they will inform a lot of our clinical counseling and support our current evidence-based management of patients with these inflammatory polyradicular neuropathies.
Yeah, we really appreciate it. This bedside to bench, back to bedside approach and informing care. It's a great story. It inspires all of us to do more in the clinical practice and to be aware of these things and to be curious. So with that, we really appreciate your time. I encourage people to check out the article, Neural Synaptic Vesicle Autoimmunity, following aerosolized porcine neural tissue exposure, insight into autoimmune inflammatory polyradiculopathy. Div, thanks again.
Thank you, Justin.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.